Over to you, ma'am. Dr. Ruchi, ma'am, and Dr. Dinesh, sir.
I got a report of APTT is 45 seconds. It doesn't mean anything to me. It is just number. Because a normal report, if I say, because keep in our mind and okay, so today we are going to discuss few cases and we are trying to discuss these things in a very simple manner. Once any patient comes to you with the bleeding history, what we should keep in our mind and how we should approach to this case step by step. So here we have our students, so we will discuss with them and take their opinion, how they deal it with in their routine case. So me and Dr. Ruchi will take a few cases. So who is going to do it first?
Me, Dr. Nisha.
Okay, Nisha. So here is a you got a report of APTT 45 second, the control is 30 second and the range is 28 to 35 second. So what it means to you?
So it means that the APTT time has prolonged, which means that the intrinsic pathway and the common pathway may have the problem may be in the intrinsic pathway or in the common pathway of the coagulation. The patient has a prolonged clotting time.
Anyone else would like to add something? Okay, so for me, if I got a report of APTT is 45 second, it doesn't mean anything to me. It is just number. Because a normal report, if I say, because any without history, without examination, these are just number. Okay, I just tell you a few examples how it changed the scenario. If I say it is a preterm baby, okay, and APTT is 45, so the normal range for them is till 48 seconds. Okay, so it is normal for that. If I say it is male patient who has occasional bleed, so it could be a factor deficiency of intrinsic pathway. If I say it is female patient who has epistaxis and menorrhagia, then it could be a von Wien. Okay, or it is a some 60-year-old guy who has just recent few history of bleeding. Then it could be any inhibitors, anything. So the moral of the story, it is just you have to interpret every value of any test with the history. Without history, don't try to interpret it. It is just a number. You just give it a value if you don't have any history. So don't give any final diagnosis or conclusion on the base of just on the test. Okay.
Okay, sir.
So that is the importance of history in coagulation or any other scenario which we deal with the. So how we approach a case of bleeding disorders. So usually whenever we have see any patient or patient comes to us, so few questions, what questions should come to your mind? What you expect to know from any patient? What type of history you want to know?
So first of all, the duration of the bleeding, or whether the bleeding is after trauma or some internal bleeding, then patient is having prolonged bleeding during after surgeries only, or after trauma also he's having bleedings. And then in any family member, the patient has a similar history in the any family member or in the extended family members, then the age of the patient, it which is the patient is presenting with the bleeding history.
So basically we have to ask few questions to ourselves. Then you come to know what we are dealing with and how we should go further. Okay. So first we want to know whether it is true bleeder or it is just single bleed. Okay. So Other thing, what is the time of onset of bleed, or whether there any other family member is there. If it is early in stage, most probably it is inherited. In late stage, who has never presented with bleed means acquired. What is type of bleed, whether it is petechiae, ecchymosis only, epistaxis, menorrhagia. These are more type of primary hemostatic disorder. Whenever deep-seated hematomas or joint bleed, this type of bleed are mainly cognitive activity disorder or secondary hemostasis. Then severity will tell whether it needs intervention or some transfusion or something, or how many, what is the inheritance pattern, whether all male are affected means X links, both the sex are affected means it is autosomal. So whenever the patient comes to you, you should ask this question to yourself. Okay, then you come to know what type of disorder we are dealing with. So these are a few differentiating point where we can somehow, on the basis of history and examination, we can differentiate whether it is primary hemostatic disorder or it is a secondary hemostatic disorder. Okay, so like as I told, superficial ecchymosis, petechiae, these are more common in platelet and bone urine type of disorders. Okay, and deep-seated hematomas, joint bleeds, these are hemarthrosis. These type of bleed is more commonly in coagulation disorders. Okay, as I told, the inheritance where only male are affected. So this how we can differentiate between primary and secondary disorders. So can anybody tell about this thing which I am showing on the picture just now on the slide?
So this is the coagulation pathway.
Okay, so can you explain this coagulation pathway?
So the in coagulation pathway on the
Okay, so it is
both-
very difficult. Okay, when I see such things, my condition is like this: which thing is originating from where, and which starts first, which end where. Actually, the every coagulation factor in different components are acting together. It is not one by one, but it is difficult to interpret. Okay, and today our concern is to know about how to go with this coagulation test and how should we interpret. So we simplify this in this simple y-shaped, or we can sometimes we call waterfall pattern or cascade. So it is simplified form. So one side is the intrinsic pathway, other side is extrinsic pathway, common pathway. Okay, so intrinsic start from your pre-calculin, high molecular weight calculin 12, 11, 9, and 8. And extrinsic from your tissue actor, it convert 7 into it excipium. Ultimately, both the pathway converge and they activate factor 10, which along with factor 5 and phospholipid and calcium, they make the prothrombinase complex, which convert prothrombin into thrombin. So thrombin is the boss who will decide how much the coagulation will occur and how much clot will form. And this thrombin converts fibrinogen into fibrin. Okay, so here when the fibrin is formed, that is where we will detect this clot formation in any of the one stage assays. Okay, whether it is PT, APT, factor assay, whatever it is. Okay, if it is clot based assay. So this initial fibrin formation we will detect. Okay, and this is stabilized by factor 13. So on the basis of what test we are here, we can say then if only intrinsic pathway is affected, then APTT will increase. If extrinsic, then only PT is increased. If both are, that means the problem is somewhere in between common pathway. Then we have to do TT. If TT is normal, then fibrinogen is all right. So there is defect in 10, 5 or 2. Okay. If TT is also prolonged, then means there is problem with the fibrinogen. Okay, and everything is normal, still patient had cognitive type of disorder. That's mean it is factor 13 somewhere is problem. Okay, so this is a broad thing, and we will further on the basis of these initial tests, we do mixing study, correction study, factor assay. So we will discuss along with the cases how it goes through. So here is a case. It is a 28-year-old female which presented with one abortion on first trimester. No other significant bleeding history in the past, and there is no significant family history of bleeding or any such type of abortion in the family or sisters or mothers also. And when they have done some investigation initial from the private lab, it shows PT is normal and APT is 46 seconds. which is prolonged, fibrinogen is normal, okay, and CBC is absolutely normal. So what will you, on the basis of this history, what will you suspect? How will you go for it?
We will like to repeat the tests once.
Okay. Why you want to
And
repeat the test?
sir, there's no significant bleeding history in the past, and the family history is also not there. And APTT is the only one which is prolonged. So it would be a good idea to confirm the test, sir.
Yes. So this test has been not performed in your lab. So you don't know which lab it has been performed, in which condition it has been performed. Okay. Other thing, as I told, you ask those questions in your mind. So when you ask, you didn't find this is a not a true bleeder. There is no significant history. It must be a coincidence, just a abortion. Okay. And this patient is referred to us for suspecting young female with abortion. So they suspect lupus anticoagulant and they ask for the doing further workup. So we got this thing, as I told, from outside. So as you told, there could be pre-analytical variables. So you don't know what type of samples you are getting, whether the sample has been taken properly, it has been transported within time or not. Okay. So can you tell anything about what is pre-analytical variables?
These are the variables which are not related to the analysis, matlab they are related to the collection of the
Transportation
sample.
process, collection,
Yes, sir.
and
So
the
the errors,
method of collection.
yeah, so the errors which occur before analyzing or doing the test. Okay, so it start from the doctor order for a test, whether he is ordered correct test or not. And this is the most common error which is occur in any of the testing system. So around 60-70% are pre-analytical. If you find a wrong report, that constitute around 60 to 70% is pre-analytical only. Okay, and maximum errors occur at the time of identification of the patient, because most of the patient are illiterate, they can't read English. So there is rush in OPD. They have given one form to other patient, and he has given to the phlebotomist, and they take the blood, and so everything is correct, but you put the wrong person blood in wrong labeled tubes. Okay, doesn't matter how good instrument, how good pathologist you are, if the error is occurred there, you cannot give the correct report. Then at the time of sampling, so in non-traumatic puncture should be done, and it should be done in a proper manner. Then correct order of the if you have to collect multiple samples, then the order should be correct. Okay, like EDTA you cannot take before citrate. Why?
EDTA will chelate the calcium and it will hamper the coagulation.
Both the chelate the calcium, but EDTA has powder. So once it pierces the needle, some EDTA will stick around this needle, and when you put it into the citrate vial, EDTA is irreversible and uncontrolled calcium chelator, whereas citrate is a controlled. Okay, so that's how you have to follow a particular adder. And if the hematocrit is more than 60, then you have to adjust the anticoagulant volume, and it should be transported to the lab within time. Okay, and once sample reaches the lab, it should be checked for labeling correct sample, while it's not spilled over or it is not broken. It is properly labeled, the correct tube has come for the correct test, and there is no hemolysis or clotted sample, and it should be processed within time. And if you are going to do the test, then you have to do it immediately, or you should store it properly. And we should not forget about the patient variables also. So these are few pre-analytical errors. In this case, actually we found out that patient has given sample to somewhere in a local small place, and it has transport to some other place. So there is due to this transportation things, it has been lost the factor levels of whatever. So that's why the results are anomalous. So this is the importance of the pre-analytical variables. So whenever you do the test, you have to check about the prenatal. Okay. So who will take the next case?
Sir, I'll take it.
Okay. So here is
So-
3-year-old male patient who has presented with swelling and purple scalp swelling since the last 4 days. There is past history of hematoma on scalp after falling from the bed, and is minus bruise after the minus trauma. Okay, and these resolve spontaneously after some times. And some of these type of hematomas are spontaneous also. He has family history of maternal uncle, his cousin has similar type of bleed. Okay, so this is the pedigree of this patient. So on the basis of that questions which I told you initially, can you now interpret what type of disorder you are suspecting and what it
Yes,
could be?
sir. Yes, sir. So it's a young male. So age of onset is young. There's history of recurrent bleeding, and there is a family history. So it is, and it has been observed that the males are affected. So it is mostly S-linked uh, disease, and both the parents were not affected, and it is shown in the males. So it's X-linked recessive disease.
Yes.
So
And
we
what
know
type of whether it is primary hemostatic defect or secondary?
secondary hemostatic, sir.
Secondary hemostatic. So it is congenital or acquired?
Congenital.
Yes. So it gives you answers, na?
Yes, sir.
Okay. So okay. So now you think it is a congenital disorder of some cognitive factor deficiency. Clear? That
Yes,
is
sir.
what you want to tell. Okay.
Yes, sir.
So how will you proceed further?
Sir, we'll go for a basic panel of tests, which are APTT-PT, and we'll, according to that test, we'll
That is the
move
only
on.
thing you want to look to? PT and APTT? Anything else?
Yes, sir. We will also look for the platelet counts
Yes. Platelet count and morphology. Okay.
and morphology.
And
Yes.
blood smears also.
Yes, sir.
Okay.
Yes, sir.
So in this patient, as you told, it is tube bleeder. It is severe because it requires transfusion or not. Okay. So here, these are the minimal screening panel which you have to do: platelet count and morphology, and you should look smear also. Sometimes in APML or some leukemia, there is thrombocytopenia, and due to that bleeding is there. So you can find out those abnormal things in that smears. Similarly, the platelet, some syndromic, you will find Dole body or some inclusion. Those things are giant platelets. Those you can see on the smear. It will give you a further clue. And PT and APTT. So minimum these 3 tests you have to do along with the history. And if needed, you can go for thrombin time, fibrinogen, and bleeding time. Okay. So in this case, the platelet count is normal, PT is normal, but APTT is prolonged. It's 71 seconds.
Yes,
So
sir.
now what will you do?
Sir, it is mostly deficiency in the intrinsic pathway. So it could be factor 12, 11, 10, and 8 factor. And we know that 8 is the most.
Ceremony, one thing. You told about the factor 12. So do you
Yes,
think
sir.
factor 12 deficiency patient bleeds?
No, sir.
Yeah.
Mostly
So
they don't.
if you have heard Dr. Sukesh Nair's talk, he told the story of Mr. Hegman, the person after whom the factor 12 name is there. Hegman factor, that's why we say. So that patient
Yes, sir.
died of thrombosis. Okay, so
Yes.
these patients never bleed, even the EPTT is 120, 130, they never bleed. Okay, so factor 12 is out because you know the history. Yes. So we have remained with the 11, 9, and 8. Is it correct?
Yes, sir.
Yeah.
Yes,
So
sir.
what do you want next? What step you will do?
Sir, it could be either factor deficiency or it could be also inhibitors. But being young age and family history, we'll suspect more factor deficiencies. But
Yes.
we'll like to do mixing studies to rule out the possibility, and then we'll like to do factor assays if it suggests factor deficiency.
Okay. So what do you mean by mixing study?
In mixing studies, we sir generally take 50% of the patient's sera plasma and 50% of the
And one thing, in coagulation, we deal with plasma. Hardly
plasma.
we
Yes,
deal with serum. Okay, in
yes, sir.
biochemistry, we deal with serum. So in coagulation, it is more of them plasma. That's why my slide is also blue, like citrate vial.
Yes, sir. 50% patient plasma and 50% normal plasma, and then we'll mix and we'll observe the clot formation, agglutination,
Agglutination. No,
clot
it is
formation, no agglutination. Sorry.
correction of the prolonged
Yes, sir.
test, whatever it is, whether PT or APTT. Okay.
Yes.
So basically, what we are doing in normal pool plasma, there is all factors are in normal concentration. Okay. So whatever factor is deficient, if it is there, it will correct it. Okay. And if it is inhibitor, it will inhibit the factor, that particular factor in that normal pool plasma. So it will not. Okay. That's how we are able to differentiate between factor deficiency and inhibitor. Is it clear?
Inhibitors. Yes.
Okay.
Yes, sir.
So I don't know why I'm not able to go next. I'm not able to move my slide. Okay. So that is what you have told me, that half of the pool normal plasma and half the factor, basically patient plasma, you mix it and do the test. So here our APTT is long. That's why we are doing APTT. Okay. So suppose this is corrected with your pool normal plasma. So it tell you it is factor deficiency. So what next you want to do? You can do anything else except this mixing study.
Thromboplastin time.
No, that is already normal. PT is normal, na?
Yes, sir. So there's one. I'm not able to recall the test.
Okay. So actually now we know it is factor deficient, and we know
Yes.
it could be either 11, it could be 9 or 8. Is it clear? So we
Yes.
want to know which factor deficiency it is. So
Yes,
there
sir.
is, we have to mix either that particular deficient plasma with patient plasma and come to know which factor is deficient, or these factors are costly, so we can simply do adsorb plasma and ACE plasma. So it is simple to make. So adsorb plasma, all the factor 2 dependent factors are depleted from adsorb plasma. So your 2, 7, 9 and 10 will out. It will remain
Yes.
8, because we are now here talking about only 8, 9 and 11 and 12. Okay.
Yes, sir.
And in aged, your factor 8 and 5 are labile. So they will short half-life, so they will go away. So here is no 5 and no 8. Okay. So that's how now we will mix with it. So if we will going to mix with like adsorb plasma and ACE plasma. So if it is corrected with adsorb, so what adsorb has 8, but it doesn't have 9. So
Yes,
if it's
sir.
corrected means it is factor 8 deficiency. Vice versa, if it is corrected with ACE but not correcting with the adsorb, it means it is factor 9.
9.
And if it is corrected with both, so both have 11 and 12. Okay,
Yes,
so
sir.
it could be either 11 or it could be either 12 deficiency. But we know factor
12 is rare.
patient never bleeds. That's
Yeah.
how it will be factor 11. Is it clear to you?
Yes, sir.
All of you, I hope. And same thing, as I told, if you have deficient factors, you can do the same things and you can find out which type of deficiency it is. Is it clear? So now I will just summarize the test, whatever the test. So it correct with pool normal plasma. So what it mean to us? Patient plasma has been corrected with the pool normal plasma.
Which means patient has a factor deficiency and now it is being corrected.
Yes. So it has factor deficiency.
Yep.
Now it corrects with adsorb plasma, but no correction with adsorb ACE serum. So what it is now?
Factor 8 deficiency.
Factor 8
Eight
deficiency.
deficiency. So now you know it is factor 8 deficiency. So what will you do next?
So factor 8 assay.
Assay.
Factor 8 assay, because we have to categorize the severity of this patient, whether it is mild, moderate, and severe, because according to that we have to treat these patient. Okay. So how we do? Either one stage, two stage, or chromogenic assay. One stage is most common. So can anybody tell me what is the principle of one stage assay? Okay, for the saving my time, I just explain you very simple. Okay, so suppose if I have to measure my height, what I will do? I can tell you you are long, short, or it is normal, but we cannot tell exact how tall you are. For that we need a scale. So here what we do, we have a calibrator which we values we know, and we do the serial dilation, and we measure how much patient plasma is correcting that factor 8 deficient test. Okay, so what degree it is correcting, and then we compare with the calibrator or standard plasma with the known values. So this is simple. So anybody has done these factor assays in their lab?
Yes.
Okay, if you are not done, doesn't matter. So what we need: patient plasma, factor 8 deficient plasma, activator means that is APTT reagent, and phospholipid. So once we mix it and recalcify it, and we note the clotting time. So how we do? Actually, minimum 3 dilution we have to do. Usually we do 1:10, 1:20, and 1:40. And we make a serial dilution of this for both calibrator and plasma, test plasma. Okay. Then we do the APTT. This APTT is a little bit different. What we do, first we put patient plasma, then we add 100 microliter of factor deficient plasma, whatever, whether it is 8 if we are measuring, if it is 9 we are measuring, then factor 9 deficient plasma, then APTT reagent, and we keep it for incubation, and after 5 minutes we add calcium chloride, and then measure the clot for all calibrators, 3 dilutions of calibrator and 3 dilutions of patient. So and we plotted these value against concentration of factor 8 in APTT in second. Okay, so here I just, for your simplification, suppose we get these values on the right side. If you're seeing for patient and calibrators, 1:10, 1:20, and 40, then we plot against this. 1:10 we consider as 100%. So these 3 value for the calibrator, and we join this line. Then similar type of points, whether it is 69, 75, and 81. So we again plotted again these concentration, and we again join this line. So we get these 2 lines, one for patient, one for calibrators. And then we put a horizontal line wherever this cut to the calibrator line, we drop it down and see what is the value over there. Like first is 9.8, then 4.8, 2.8, suppose it is. Then we have to multiply with the dilution and take the mean of these 3 values. And as I told that if it is 100%, then the correction factor is 1, but it is never 100. So either it is 110 or something. So we have to multiply with this correction factor. For 110, it is 1.1. If it is 90, then 0.9. Okay. And then multiply, and then we find it is the final factor value is 10.6, and we diagnose as mild hemophilia A case. Okay, so that's how we do the factor 8 testing. So this patient is less than 1%. What do you mean by this?
I would just like to ask if it is clear, because it is slightly complicated, and if it is not clear, this is the right time to ask your queries.
Yeah, I can explain it again if you want.
Let us
sir.
first get hands on how many understood the test. So, Ruveka, Divya, did you understand the test?
Yes, I know it is difficult.
Amad,
Please again, ma'am.
you need it again. And Arundhati,
Yes, ma'am, repeat it once.
one more. That's why I said
So
I think you should go back from how you prepare the dilutions of the calibrator. I
Okay.
think
So like we have 3 glass plastic tubes, always we do dilution in plastic tubes, so the factors does not activate. Okay, the coagulation factor does not activate. So we take 3 tubes for the calibrator and 3 tubes for the patient, and we label tube 1, 2, and 3. First tube labeled as 110 dilution, another is 120 and 140. Is it clear?
Yes, sir.
In first tube, we take imidazole buffer, that is 0.9 ml, and next two tube we take 0.55 ml. Is it clear?
Yes, sir.
Okay, sir.
Now, in first tube, we take if we are making for the calibrator, then we take 100 microliter for calibrator and mix in this. So 100 in 0.9, it makes 1:10 dilution. Is it clear?
Yes, sir.
And from now, this first tube, we aspirate 500 microliter, that is 0.5 ml. Okay, and go into the second tube. So it is here 0.5, and we are adding 1:10 in this, so it makes 1:20. Is it clear? It is simple serial dilation. Okay.
Yes, sir.
And next, for making 1:40, from 1:20 tube, we again take 0.5, and if we'll make with the buffer, again it will go into twice. So it is 1:40. So that's how we make the for dilution for calibrator and patient. Clear?
so why are we making dilutions?
Because ma'am, if dilution के through हम लोग if a factor is deficient, then it will be deficient on every dilution.
Right, but then you can test it at one dilution also.
Ma'am, to correct the more to find the more correct values.
Yeah, that makes your essay accurate. And though we have not, I think, included that part, but there are importance of putting up 3 tubes so that you know that the test you have put up, when you do it manually, you are getting the correct results, because it should be a straight line. Both the calibrated and the patient lines should be parallel before you start calculating your factor levels. So if you look at these values which he plots on the graph, so if you will notice that these lines are parallel. If they are converging or diverging, they'll indicate that the test which you have put up is not correct, right? So it is recommended that at least you should do 3 dilutions before you, and not read the value of just from one single dilution, right? Anything to add, Dinesh?
Yes. So that's how I told you. You just take a semi-log paper, and one side you plot APTT in second, and other is take the concentration of factor 8. So 1:10 we consider as 100%. So suppose my for calibrator my value is 50. So here is 50. This is 100. I take it. So we put 1 point over here, 1 point over here. Okay, from 100. 1:20 is 55. So 1:20 is 50%. Here it is 55, and then 60 for 1:40. And then we join this line, and similar thing we will do for the patient also, and that's how we calculate the value. Okay, so in this patient, the factor value is less than 1%. So how will you classify this patient now?
Severe.
Severe.
Severe hemophilia. ठीक है, severe hemophilia, because factor 8 is deficient, that's why it is severe hemophilia A. Okay, so we will quickly move to the case number 2. Who will take this case number 2? Okay, so here is a 30-year-old male child, known case of moderate hemophilia. His factor 2 level is 2%. He diagnosed at the age of 6 months. Now he is 13-year-old. Okay. Now he is referred to our center with recurrent gastrointestinal bleed since last 8 months. This time, this bleed is so severe, it is not stopping even after giving the recombinant factor 8, which is the treatment of choice for this patient. And the bleeding is persistent even after overcorrection. Okay, these factors. So what could be your differential diagnosis in this patient with this history?
Sir, the child is already a known case of hemophilia A. and have been treated with recombinant factor VIII. But bleeding persisted after full correction, maybe due to inhibitor
Yeah, development inhibitors. So same things
bleeding.
our physician have also thought. This thought it is hemophilia who has developed now inhibitor. That's why whatever factor is we are giving, it is neutralizing and it not able to stop the bleed. So we did the test, screening test as usual. It is PD is normal and APT is 59.4%. Okay, 4 seconds, sorry. So, and it is corrected with PNP. So that's how we see ki it is not looking like inhibitor, but still time dependent inhibitor can be there, which cannot be picked up with the immediate thing. So we have to do inhibitor screening for that. Okay. So we do inhibitor screening. In the next case, Dr. Ruchi will explain how we do the inhibitor screening. Basically, it is the simple mixing study. We just incubate patient plasma with the pool normal plasma for a particular time on a 37 degrees centigrade. So if the antibody, that is inhibitor is antibody that act on the particular factor, if they are present, it will neutralize the present factor, that particular factor. So your APTT or PT will prolong. That's how we will find out whether there is inhibitor or not. Okay, so this is the basic principle of inhibitor. How it do, Dr. Ruchi will explain to you. And in our lab, we will take, if it is 8 or more than 8 is a positive, it is less than 8, actually we take 5 or less than 5 is negative, and 6 to 8 is somewhere are equivocal, and we will ask to do more sensitive test for this. Okay, so in this patient, we did the inhibitor screening and it was negative. So what is your next thing? What do you think now?
Von Willebrand disease.
Why von Willebrand disease? Still, I say it is negative. So they again did this. What we say it is a serial monitoring of factor 8. So pre-infusion factor 8 is 3. Then after half an hour of giving full dose of factor 8, it is 29. And after 8 hours, it is again 4%. And after 24 hours, it is again 3%. So they say, please repeat the inhibitor. It is maybe inhibitor. So we again did the inhibitor screening and it is negative. So what actually we are missing in this case? So anybody has recognized the history? So what is the history suggest? Have you seen this?
Immediate past 8 months recurrent bleeding.
Gastrointestinal bleed, which is more common in primary type of. So we ask, till the time that patient father is very anxious and he's come to me in lab to know the results. So I asked the history from the beginning. So he told me there is prolonged history from the injection site during immunization. His history of ecchymosis, gum bleed when during the brushing, and epistaxis also. He has also bleed whenever there is cut or some trauma, superficial trauma. Okay, and there is never history of joint bleed or any muscle bleed, and similar type of any complaint in any family member. So if now this is the history which I got from that patient, and what this history suggests to you.
Primary hemostasis.
Primary hemostasis abnormality, sir.
Yes. So this patient, it is real case which we diagnose in our lab, and there is many other case where the history has not been proper and the proper investigation has not been done. Okay, and because we never look for that, we never ask for that. That's why we are not thinking of that, and we are not doing those tests particular. Okay, so now the scenario is totally changed after getting the history. Okay, so it is primary hemostatic disorder and some part of secondary hemostatic disorder. So this is what
Von
the
Willebrand
disease is fitted. Okay, because in platelet type of disorder or factor 13 deficiency, these are two the other things where such type of bleed can occur. But your APTD is prolonged. in other two conditions, your APTT and PT will be normal. Is it clear? So that time we have to do, because factor 1 billion assay will take time. So we did the platelet function test, and it showed no response to ristocetin. This blue one is the ristocetin. When we mix patient plasma with PNP, PNP provide the 1 billion factor. So it corrects the ristocetin. So it makes the diagnosis of von Willebrand disease.
Von Willebrand disease.
Yeah. So later on, we did the what you want to do next to make the von Willebrand disease particular diagnosis.
Von Willebrand assay.
Antigen. Anything else you would like to add in this? Only von Willebrand antigen?
Von Willebrand activity.
So at least minimum these two tests you have to do along with factor 8 level. Okay. And obviously the screening test you have to do your platelet count, PT, APTT. Okay. So in this patient, when we did von Willebrand antigen assay, it is no detectable von Willebrand antigen level. So we diagnosed it as type 3 von Willebrand disease, which is severe type of von Willebrand disease. And then we convince these physician and ask to give the another product of factor replacement therapy which contain von Willebrand factor also. And we did the serial monitoring after that, and it showed the persistent of factor 8 level. Okay, so that's how we diagnose this case. So the motto of showing this case is we have to emphasize history again and again, because this is the most important test which will give you how to proceed further, what test you do, and the correct interpretation of these values. Okay, because this is a very good example how the total diagnosis is changed in this patient. Okay. So can anybody explain how we go for diagnosis of von Willebrand disease?
So sorry to interrupt. There's a request to use laser pointer. If possible, you can show them, sir. Laser pointer. Or you can annotate, sir. It's in the right corner. Yes, sir.
Okay. So can anybody explain, or I just explain? Okay, so first thing, you should know the history. That is very important. So usually mucocutaneous type of bleeds are there. So as I told, PTA, PTT and platelet count we have to do. And sometimes all these PT, APTT and platelet count is normal, and APTT can be prolonged. So we have to do antigen and Rakoff assay and factor 8. Okay. So then we have to take the ratio of activity and antigen. So it is the old one where the cutoff is 0.6. Now they have taken, they don't want to miss any mild cases also. So they increase this cutoff from 0.6 to 0.7 now. Okay. So if it is more than 0.7, then it is either type 1. Okay. If it is less than 0.7, then it is type 2. So we further know it is further subclassified. So suppose it is there is no detectable antigen, then definitely it is type 3. But if it is activity and this ratio is more than 0.7, then it is type 1. And we have to again do propeptide assay. If it is increased, then definitely it is type C. This is new category of it. Okay. The other scenario where the this activity and antigen ratio is less than 0.7, so we are suspecting type 2. So if thrombocytopenia is there, then type 2B is suspected, and it shows increased response in low dose resuscitation-induced platelet aggregation. Okay, so it is type 2B, and if it is normal, then type 2A or type 2M and type 2N. So type 2N again has low factor 8. Okay, and normal your von Willebrand antigen assay. So that's how we just because there is long explanation for this whole chart. Just in short, I just explain you how to go with this von Willebrand disease. So here I will hand over to Dr. Ruchi they will take you some more interesting case in coagulation. So ma'am, can you continue with Next is and can you share us the screen? You are not audible, ma'am.
Okay. Is it visible?
Yes,
Yes,
now
ma'am.
it's visible.
Okay. So for case 3, we have Ruveka.
Yes, ma'am.
Okay. So what is the history provided?
History is 32-year-old female with echymosis for the past 7 days all over the body. She developed it 2 months postpartum, and there is no past or family history. There is no organomegaly or lymphadenopathy, ma'am.
Right.
And yes, ma'am. Her PT value is on the upper limit of
Yeah,
normal.
just hold on. So what do you understand from the history? What is it trying to tell you?
Yes, ma'am. She's a female and she developed it postpartum, 2 months postpartum. So it is not a congenital disorder. So she has acquired it recently, and there is no past or family history. So this also rules out the congenital disorder or inherited disorder. And
Right.
there is no organ. Yes, ma'am.
Perfect. So that is what the history is telling you, that since there is no past history, no family history, sudden first episode at 32 years of age and short duration of 7 days. So there must have been some precipitating event because of which she has probably developed something, and she is now presenting acutely with bleeding. So
Yes, ma'am.
usually it is believed that these kind of acquired conditions usually present later in life, and it is very rare to get acquired conditions in the childhood stage. But I always remember Dr. Jasmina does show us a case of a 3 or a 4-year-old child who presented actually with a acquired defect. But usually if you see, usually you will have these are the bimodal presentation. There is no specific sex predilection for acquired disorders. But and specifically if you look at females during pregnancy or in the postpartum period, this condition is quite frequent, right? So the
Yes, ma'am.
most important thing which you could catch from the history was that this is a acquired defect. So then
Yes, ma'am.
we had the basic lab values.
Yes, ma'am. The lab values shows PT value, which is on the upper limit of normal. APTT is increased, fibrinogen level and thrombin time are normal. The other normal CBC parameters like hemoglobin is decreased. The total count, differential count, the platelet, iron studies, B12 and folate level, everything is normal, ma'am.
Right. So what is wrong? Basically, which parameter is deranged?
APTT, ma'am, activated partial thromboplastin time is increased.
So we have an isolated APTT prolongation.
Yes, ma'am.
So how do you want to proceed now?
Now, with just isolated APTT prolongation, I have the following DDs. It could be factor 2, 5, 10 deficiency or the factor intrinsic pathway factor deficiency, ma'am. Or it can be due to factor A deficiency secondary to von Willebrand disease. But as per history, the patient has developed it recently. It's not a congenital one.
So you
And
said one of your differentials was factor 2, 5, 10 deficiency, right?
yes, ma'am.
So why 2, 5, 10 deficiency? Would not that affect the common pathway, and then both PT and APTT should have been prolonged? So
Yes,
it
ma'am.
was like just marginally prolonged, right?
Yes, ma'am. So it's not included, ma'am. I
Right.
have the
So
following DDs. Yes, ma'am.
yeah. So that
Yes,
comes
ma'am.
low. That should be lower down, or in fact, it should probably, if you are talking about isolated APTT prolongation, then the common pathway defects will probably not come even in your differential, right?
Yes, ma'am. Yes, ma'am.
So
I have the following DDs, ma'am. First one is I suspect either disseminated intravascular coagulation, but it is ruled out, ma'am, because platelet level is normal. And second possibility is primary fibrinogenolysis, and it is also ruled out because fibrinogen level is normal. Third thing I suspected is liver disease because like HELLP syndrome, but here the platelet count is normal, so liver disease is also ruled out. It could be vitamin K deficiency also, but I keep it as one of my DD. The other possibility is specific factor inhibitors.
Right.
The specific factor inhibitor, and the last one is lupus anticoagulant. But the problem is the lupus patient do not bleed, but this patient is bleeding, and most common complication of the lupus is the thrombotic complication.
Right.
But in this case, the patient is bleeding, ma'am. So I got two main
Uh,
differentials.
Right. So exactly.
Yes,
So
ma'am.
Rebecca, frankly, if you ask me in this condition, it definitely is an acquired defect, right? It
Yes,
looks
ma'am.
like
Yes,
an
ma'am.
inhibitor, right?
Yes, ma'am.
So my first
Yes, ma'am.
possibility would be to rule out a specific factor inhibitor. And then
Yes,
lupus
ma'am.
definitely, again, before we go to specific factor inhibitor, lupus tops the list. So these are the two primary differentials. The rest which
Yes,
you have
ma'am.
listed, actually, if you go back to your own list, you will realize that in majority of those, like DIC, fibrinogenolysis, terms like these,
Yes,
they
ma'am.
will have a very, the patient would be sick. Your PTAPDT
Yes, ma'am.
in a fibrinogen related disorder, both PTAPDT would be significantly prolonged, your thrombin time would be prolonged, right?
Yes,
DIC
ma'am.
may
Yes,
platelets,
ma'am.
etc. would be affected. So
Yes,
so we didn't really tell
ma'am.
you that we didn't say that the patient was sick or in an ICU or that kind of a setting. We just said that she's presented with ecchymosis, which is of short duration. And what is interesting is that recently she had a full-term normal vaginal delivery. There was no history of excessive bleeding. So that means something has happened in the postpartum period. So it is like an acquired state. And
Yes, ma'am.
right. So
Yes,
how
ma'am.
will you go further? So fibrinogen and all and thrombin time we have already given. So these are all normal. So other differentials are automatically out.
Yes, ma'am.
So
But
what do we want to do now?
now the patient is having isolated APTT prolongation. So I thought with mainly factor 8 inhibitor, which is acquired postpartum, ma'am.
Next
So I
test.
thought
Next
inhibitor
test.
to
Yeah. What is your next test?
next test to confirm whether it is an inhibitor by correction studies, mixing studies.
Right. So that perfect answer. So you have an isolated APTT prolongation. We do not know it is either due to a factor deficiency or it is due to a inhibitor.
Inhibitor
The best thing
deficiency.
to do is do a mixing study, right? This
Yes,
part
ma'am.
we've already gone over. So
Yes, ma'am.
I just want to stress one point that we are dealing with acquired defect, and the bleeding phenotype in an acquired defect can be variable, right? They can have mild
Yes,
bleeding
ma'am.
disorders or they can even have light threatening bleeds. So, like
Yes, ma'am.
supposedly you pointed out that we have an inhibitor against factor 8 or an acquired
8.
factor 8 inhibitor. So these patients
Yes,
will
ma'am.
not come to us like a typical hemophiliac with joint bleeds.
Yes,
Hematosis
ma'am.
is rare in such disorders. Rather, the more common manifestations are skin bleeds like ecchymosis, some subcutaneous hematomas, mucosal bleeds, and so on. So some of your questions will actually fall in the gray zone in this area. Like I
Yes,
said, what
ma'am.
is the type and site of bleeding? So the patient has come with ecchymosis, which looks like a primary hemostatic disorder. But no, we are not dealing with a primary hemostatic disorder over here, right? So that's
Yes,
why you
ma'am.
have to be careful, and sometimes you will need to take the help of lab tests also to answer some of these questions which you have to, get back to yourself and ensure, okay, so what am I dealing with, right?
Yes, ma'am. Yes, ma'am.
So the next step is, as you rightly said, it's a mixing study. So what are we doing in mixing study? We mix equal volumes of the test plasma or the patient plasma with pooled normal
With the
plasma,
control.
right? So
Yes, ma'am.
even when you
Yes,
are
ma'am.
giving 50% of the normal factors, your APTT should correct if there is a
Correct, ma'am.
deficiency. But in this
Yes, ma'am.
particular case, we can see that when even on adding your pooled normal plasma, the value is 78 seconds. So that indicates that
Yes,
your
ma'am.
APTT has not corrected. So that indicates
Yes,
there is
ma'am.
some inhibitor.
Inhibitor.
Right. So Dinesh has already explained partly inhibitor screening. For inhibitor screening, what we need to do is that you need to take, initially you will take 2 tubes where you have neat patient pool normal plasma, and in tube 2 you have neat patient plasma. The third tube which is there is a mix of the pooled normal plasma and the patient plasma. So initially for 2 hours you will incubate all these 3 tubes at 37 degrees centigrade in the water bath, right? After 2
Yes, ma'am.
hours, why are we incubating for 2 hours?
So that
For the
Because long
factors to
late inhibitor.
Because late
Formulation
inhibitors will
factor.
act only after incubation for 2 hours. So we have to check for whether
Not
it is
all
late inhibitor.
inhibitors. Not all inhibitors will act like that. Which inhibitors?
Because factor 8 inhibitor is a late inhibitor, ma'am. So
Right.
for this test, we have to incubate it for 2 hours.
Right. So factor 8 inhibitor is a time dependent inhibitor, whereas factor 9 inhibitor is a immediate acting inhibitor. But there is a catch over here. If you have very high titers of factor 8 inhibitor, then also when you will mix, even on immediate mixing, there will be no correction. Right? So that
Yes, ma'am.
sometimes in hemophilia patients, hemophilia A patients, when you get such a patient, where the APTT is prolonged, and when you do your mixing study and it is not correcting even on immediate mix, that immediately gives you a clue that you are probably dealing with a patient with a high titer inhibitor. Right? So
Okay, ma'am.
traditionally, to remember, yes, factor 8 inhibitors are time dependent. That is why you incubate. But sometimes if the titers are very high, then you can have, no correction even in a fresh mix. So again, going back to the test, so you have these 3 tubes which you incubated for 2 hours. And then after 2 hours, you mix these tubes again. And this is now called as a fresh mix. And this is known as the incubated mix.
Incubate mix.
Right. So if the difference between this fresh mix and this incubated mix is more than 8 seconds, that is what we have taken in our lab as positive for inhibitor.
Inhibition.
Right. So, but in our
Okay.
case, as we can see that even on immediate mixing, the APTT has not corrected. So, I would actually fall back on myself, and I'll think that probably we are dealing with a inhibitor which has a high titer. Right. So then what is the next step?
Specific factor assay, like inhibitor.
So we'll do the inhibitor assay. What is the inhibitor assay known as? So before you go on to an inhibitor, it is always worthwhile to rule out lupus, right? So you'll do the dilute Russell Viper venom based test, or as it is recommended to do first, by 2 different mechanisms. You need to rule out lupus anticoagulant, and then you need to do a factor 8 assay or a factor 9 assay to specifically determine which factor appears to be affected. And then now that you know that your factor 8 is less than 1%, you will go ahead with doing a classical Bethesda assay, and in this patient it turned out to be a high titer, which was 512 Bethesda units. So since it will be time consuming to actually explain how a Bethesda assay is being done, but what you can remember is that again, like you do it for factor 8 assay, again here we make serial dilutions, right? And then we see how much inhibitor is there in the patient's plasma, which is neutralizing the factor 8 which is there in the pool normal plasma, right? And then at the end of the 2-hour incubation, we measure the residual factor 8 value, right? So not purposefully the essay over here. It is slightly complicated, but you can always go back and read, and we can discuss, right? So again, another catch in this is that sometimes when you have a high titer inhibitor, supposedly if I would have done a factor 9 assay over here, my value might have come as 5% or 10%, right? So when you have a high titer inhibitor, that can falsely affect other factor levels also. So what you can do is, if you do a dilution of the test plasma and then run the assay again, then you will realize that when you are doing a dilution, the antibodies are getting diluted. So those which are acting specifically against factor 8 would still result in a low factor 8 level, but your factor 9 levels will tend to normalize. If I run this test on a diluted sample, then my factor 8 would still be 1%, but factor 9 level would probably come up to 30, 40 or something of that sort. So that helps you to discriminate, right? So my inhibitor is specifically against factor 8. So even on dilution, it is affecting only factor 8, while the other factor levels have normalized. Anybody? Did everybody understand what I said?
Yes.
Right. So summary of this case before we move on is that you have an isolated prolonged APTT. You should always know the history, that what kind of, is the patient on any drugs, right? If it is not, is it acquired stage or an inherited stage? if it is unexplained or patient is bleeding, then the next step is obviously doing a mixing study. If it gets corrected, means that there is a factor deficiency. If it does not correct, do a factor 8 concentration level. If it is normal, then consider some another inhibitor, lupus anticoagulant. Or if the factor 8 concentration is low, then it is very likely that you are dealing with acquired hemophilia A, and then you need to do a Bethesda assay to confirm and get the antibody titers. Right?
Yes,
Yeah.
ma'am.
Okay. So next case. So we have Ahmad, you will be taking the next case.
Yes, ma'am. Yes, ma'am. So history is 15-year-old female presented with history of menorrhagia since menarche and 20 on hormonal therapy. This past history of easy visibility, epistaxis, prolonged bleeding after tooth extraction. No history of blood transfusion, but a history of occasional epistaxis and prolonged bleeding after minor. So, ma'am, since since there is recurrence, then she is true bleeder.
Right.
Okay, ma'am. Okay, ma'am. And then the age of onset is young age. 15 years is sort of young age, and there is a history of family history of bleeding. Then it is an inherited defect.
Right.
And then the site is superficial, then like mucocutaneous. Then
Because she has menorrhagia and she has some history of bruisability, epistaxis, and
visibility.
prolonged bleeding after, which is usually like a
Okay.
primary hemostatic defect. But what is not
Yes.
usual? What is not going with the primary hemostatic defect?
Ma'am, primary hemostatic defect is there is mucocutaneous bleeding, not and history of transfusion.
Usually, primary hemostatic defects will not give you a positive family history. थोड़ा uncommon होता
Yes,
है to
ma'am.
find a positive family history in primary hemostatic defects. So again, I'll tell you a small catch over here when we move on. So since the brother is also affected, so we know that the family history is positive. And since the brother and the sister both are affected, so naturally it is not an X-linked disorder, right?
Yes, ma'am. Yes, ma'am.
So
And since it is an inherited disease, as per the history, then pattern of inheritance must be autosomal sort of.
right.
Then we will go for the blood tests. Then coagulation is seen. In coagulation is when PT is raised, APTT is raised. Thrombin time is normal. Fibrinogen level is normal. Hemoglobin is sort of little decrease, mildly decrease, sort of a little anemia, and TLC and platelet counts are normal.
Right.
So since PT and APTT both are raised, then we must there should be common pathway defect most likely.
Very good. So we
Then
have a common pathway defect. So what all factors will come in the common pathway?
factor 5, 10. Factor
So
5,
I've
10.
crossed 2, 5, 10 would come in the common
2, 5,
pathway,
10,
and
yes.
I've crossed out fibrinogen. Why?
TT is not.
Right. Because
Fibrinogen
TT is normal. Right?
yes.
तो thrombin time में आप क्या करते हो? You add a lot of thrombin to the test plasma, and thrombin time को normal होने के लिए it is dependent upon that fibrinogen. So अगर test plasma में fibrinogen is normal, then your thrombin time will be normal. So उसके ऊपर का कोई defect होगा, but fibrinogen is normal, right? So then
Yes,
you
ma'am.
end up with these three factors, that is 2, 5, and 10. So how
Yes,
do we
ma'am.
narrow down further?
Then this must be 2, 5, or 10.
Right.
Then we will go for the factor SA, and my DD comes to be factor 10, factor 5 deficiency, or
So before going
factor
to
5
individual
inhibition.
factor, individual factor SA are expensive. And none of the people who are here as students, or there are very few centers, I'll not say very few centers, but yeah, but doing a factor essay is an expensive thing. है ना, एक बार vial खोला एक factor 2 essay या 5 essay करने के लिए, these come under the category of rare bleeding disorder ना. एक patient मिलेगा 4-5 महीने तक या 2-3 महीने तक, unless until you are in CMC Vellore, right? So then, is there something else you would like to do to still narrow down कि कौन सा एक factor है जिसके लिए guide करा जाए? So you should take the help of something. What is that? Right. So we should take the help of aged serum and adsorbed plasma. So like these are the differentials. When we talk about the common pathway defect, that 2, 5, 10 deficiency में PT, APD both are prolonged. So vitamin K deficiency, because सारे 2, 7, 9, 10, these are all produced in the liver. Drugs, oral anticoagulants, lupus anticoagulants, and I have listed the acquired disorders above because actually 2, 5, 10 deficiency are relatively uncommon disorders. So, but now in our particular case, we have a history, right?
Yes,
That
ma'am.
it is an inherited defect. So we know that we are not probably dealing with any of these top 4 acquired disorders. So we'll focus on 2, 5, 10 deficiency.
Ten
And
deficiency.
if TT was also prolonged, then we would have thought of first things like rule out heparin contamination
Right.
or rule out hypo or afibrinogenemia or dysfibrinogenemia. But since TT is normal, so we are not talking about dysfibrinogenemia or afibrinogenemia, right? So actually, if you ask me, aged serum and adsorb plasma are two wonderful tools which will help you to discriminate whether you are dealing with 2, 5 or 10. And जैसे कि आप जैसे दिनेश ने बताया, suppose you have a hemophilia, suspected hemophilia A or a hemophilia B, so you can, what you can do mixing studies. You can store samples of severe hemophiliacs who come to your center, right? So आपके पास एक नया सैंपल आया एपीटीटी का और आपके पास एक सिवियर हीमोफीलिया बी का सैंपल या सिवियर हीमोफीलिया ए का सैंपल ऑलरेडी पड़ा है, सो यू कैन यूज दैट फॉर मिक्सिंग, राइट? अगर इफ यू यूज दैट फॉर मिक्सिंग इन अ आइसोलेटेड एपीटीटी प्रोलॉन्गेशन जिसमें मैं हीमोफीलिया बी या फैक्टर 9 डेफिशिएंट प्लाज्मा डालूंगी और वो करेक्ट हो जाता है, दैट मीन्स प्रॉब्ली आई एम डीलिंग विद हीमोफीलिया ए, राइट? क्योंकि जो फैक्टर 9 डेफिशिएंट होगा उसमें 8 होगा, राइट? और पेशेंट प्लाज्मा में 8 नहीं था, सो मैंने मिक्स किया तो 8 मिल गया, इसीलिए वो करेक्ट हो गया. सो यू कैन यूज दोज सैंपल्स फॉर performing your correction studies, right? And aged serum and adsorb plasma can very well be made in your own lab. You do not need any special equipment. Aged serum is basically a stored sample. Your 5 and 8 are very labile. जो बायोकेमिस्ट्री लैब में सैंपल्स आते हैं उसका सीरम कलेक्ट करके 37 डिग्री सेंटीग्रेड पे यू कीप इट फॉर 2 days and you measure that the prothrombin time of this is not more than 90 seconds, then you can use this for testing for all your mixing and correction studies. For adsorb plasma, you have to use barium sulfate. You add it to your normal pooled plasma, you centrifuge it, then you collect the supernatant and measure the prothrombin time. ये सब दिनेश ने सिखाया है हमें और लैब में स्टार्ट किया है. सो सिर्फ ये 2 प्लाज्मा जिसके लिए आपको कोई केमिकल नहीं, यू आर नॉट डिपेंडेंट ऑन बाइंग एनी एक्सपेंसिव स्टफ, नाइदर आर यू डिपेंडेंट अपॉन परचेजिंग एक्सपेंसिव फैक्टर एसेस. इफ यू कैन प्रिपेयर दीज 2 things like aged serum and adsorb plasma in your lab, so when you have a sample which has both PT and APTT prolongation, you can work out कि ये 2, 5, 10 में से क्या deficient है. So like suppose in the aged serum, as I just said, that it does not have 2, 5 and 8. Right? So if my sample is deficient in 10, aged serum has 10. So when I add aged serum to my test plasma, there will be correction. But in adsorb plasma, my vitamin K dependent factors are gone. So 2, 7, 9, 10 are not there. So इसमें मैं अगर मेरा 10 का deficiency होगा तो यहाँ पे correction नहीं होगा. Right? Similarly, if you see now, if we are looking for factor 5 deficiency, so here aged serum does not have 5. तो अगर मैं टेस्ट प्लाज्मा में 5 एजेड सीरम डालूंगी तो इसको 5 नहीं मिला, राइट? बट अगर मैं एड्सॉर्ब डालूंगी तो एड्सॉर्ब में 5 होता है, तो एपीटीटी का करेक्शन हो जाएगा, देन यू कैन लेबल इट एज फैक्टर 5 डेफिशिएंसी. Whereas if you see aged serum और एड्सॉर्ब प्लाज्मा, सीरम माने क्लॉटिंग हो चुकी है, सो यानी कि 2 भी नहीं है, राइट? सिमिलरली एड्सॉर्ब प्लाज्मा में भी 2 नहीं है. सो अगर दोनों से करेक्शन नहीं हो रहा है and your TT is normal, then probably it is a factor 2 deficiency. If TT is prolonged, then probably you are dealing with hypofibrinogenemia or afibrinogenemia. So any confusion to anybody? मैंने explain करने में कोई problem है? You want me to repeat how you can use aged serum or adsorb plasma to narrow down your differentials between 2, 5 and 10? Anybody? अरुंधति, शिरोमणि, निशा?
No, ma'am.
No, ma'am.
समझ में आ गया?
Yes, ma'am.
Yes.
अब लैब में जाकर के बना लोगे? बना लोगे?
Yes, ma'am. Yes, ma'am.
एक बना लेना.
मैं अभी तक भूल जाता हूँ. मैं
भी भूल जाती हूँ, बट लेकिन this is actually a very wonderful thing. If you can have it in your lab, you will really feel proud कि मैं इतने complicated case था, उसमें ऐसी bleeding disorder थी, सिर्फ मैंने basic PT APTT लगाया and both were prolonged and I was able to narrow down कि 2, 5, 10 में से क्या है और क्या नहीं है, right? And you can guide the patient for that one specific factor ऐसे only, ठीक है? So in this patient, so the final diagnosis obviously will have to come from that factor SA. So in this particular patient, we can see that normal pool plasma में तो सारे factors होते हैं, इसलिए correction हो गया, both PT APTT. When we did mixing with adsorbed plasma, there was no correction. But when we did mixing with aged serum, there was correction. So this was supporting a factor 10 deficiency. And when we did a factor SA, it turned out that factor 5 and 2 are normal, whereas factor 10 was on the lower
Not
side.
deficient.
Right? So what is interesting is that again, the way Dinesh has explained, the way you do factor 8, one stage factor ऐसे, उसी तरह factor 10 के लिए भी आप कर सकते हो, except that instead of measuring APTT, you use a PT based test. Right? So since these are rare disorders, there are 1-2 things I would like to point out. कि factor 10 deficiency produces a very variable bleeding tendency. If you can recall, patient को क्या था? Ecchymosis था, epistaxis था. So जो rare disorders होते हैं, rare factor वाले disorders होते हैं, if they are in the milder forms, they can present like primary hemostatic defects. Usually in the severe form, they come as, intracranial hemorrhage, umbilical stump bleeding, even hemarthrosis वगैरह, like factor 8 or factor 9. There are a lot of genotype phenotype correlation studies which you can go back and read. But if you see otherwise, so commonly factor 10 deficiencies can present with, these kind of mucocutaneous bleeds, menorrhagia, epistaxis. So अगर ये history मिलती है, so then you will have to rely on your PT and APTT results to understand either you are dealing with a primary hemostatic defect or a secondary hemostatic defect. So I'll not take much time over here, but यही था कि अगर factor 2 deficient होता है normally, तो आपका PT और APTT बहुत ज़्यादा prolonged होगा. Your values would be, very, very high, right? Because fibrinogen is the final time end chain में इसको fibrinogen से fibrin बन के you have to have the clot formation. तो जब clot ही नहीं बन रहा है तो क्या होगा? PT, APTT के values, they'll be like APTT would be like 100 seconds or even beyond. And in factor 10 deficiency, if you see, both PT and APTT are prolonged, but usually the prolongation of PT is more than APTT. So yes, थोड़े subtle clues हैं, which when you see the lab test PT, APTT, you understand that what are you probably dealing with. ठीक है? So case 5 में we have Arundhati.
Yes, ma'am.
Right. So Arundhati, what is it?
Ma'am, the histories, we have a 3.5-year-old male who is presenting with history of recurrent epistaxis since 1 year of age, which is requiring nasal packing. So here we can say that the patient is presenting at an early age. So it may be a congenital disease and history of epistaxis, which is requiring some intervention. Then there is history of GI bleed 1 year back. That is, there is history of mucocutaneous bleeding. Then history of easy bruisability and ecchymosis, and there is negative history of joint swelling and deep bleed. So our first inference is that there is a defect in the primary hemostasis, and patient is requiring PRP and FFP to stop bleedings.
So that indicates it's a severe kind of a defect, right?
Yes, ma'am. And there is no family history.
Right, very good. So we've gone through these questions.
Yes, ma'am.
So when we did a CBC, there is mild anemia and the platelet count is normal. The coagulation screen is all normal. So what do we do now?
Ma'am, since all the parameters are normal, first we'll think about, since platelet count is normal, so we can think that there might be a platelet function defect. So we'll go with the platelet function assay.
How do you do a platelet function assays? Can you tell me 3 modalities by which we can do platelet function assay?
Ma'am, since platelet functions involves adhesion, aggregation, secretion, then we can go for platelet aggregation study. Then we have a PFA, platelet function analyzer 200. We can use that automated device to estimate the platelet function.
Zyada commonly आजकल it is coming up. People are trying to switch from light transmission aggregometry to flow cytometry based testing.
Yes, ma'am. We can detect antibodies
You can detect not antibodies, you can detect the antigens. Like Glanzmann thrombasthenia, mein what is the defect?
Ma'am, Glanzmann's thrombasthenia, we have glycoprotein 2B3A receptors are deficient.
And you can tag the receptor with, actually it is CD41, so you can use anti-CD41 and see if it is present or absent. है ना? Right, very nice. So since you are already aware of what is to be done, so I'll just quickly go through it. One important test, अगर दिनेश अभी सुन रहा होगा तो फिर कहेगा कि BT नहीं बताया तुमने. So BT is a very sensitive test, but it is affected by many variables. You really need to have a very trained technician, stable hand who can consistently perform BT in the same manner so that the results can be interpreted, right? So I'll not really stress much on BT, but yeah, if you really have a trained person, then you can go ahead and screen for platelet function defects को identify करने के लिए like Glanzmann, Bernard Scholar. BT is a good question. BT is a good test, right? Then, as you said, there are multiple point of care testing equipments like you have PFA 100, Verify Now. Verify Now is a system which is used to monitor the antiplatelet drugs. ठीक है? And then routinely जो हम lab में use करते हैं, we use aggregometry. Then we take the help of platelet flow cytometry. अगर we are still suspecting a platelet function defect, then we might have to resort to very specialized test जो कि granular content जो होता है platelet का उसको study करे, जिसके लिए you will need ELISA or immunofluorescence. Then you can do platelet release assays and electron microscopy. So these lower downs are usually uncommonly used. So I'll focus more on aggregometry, though I'll quickly go through the slides of. So BT जैसा मैंने बताया, I'll not really stress. And but you should all know what is the principle, how it is done, what is IV's method, okay? What is the normal bleeding time, and the conditions where the bleeding time can be prolonged. So, so bleeding time would be affected by the platelet count, the platelet function, and even the underlying vasculature. So it is a sensitive test, but it is not a specific test. And even if it is normal, it doesn't rule out the presence of an underlying platelet function defect, right? So bleeding time has its own limitations. Next, you said that we have point of care test, we have PFA. So PFA is a simple benchtop equipment. Okay, you can do this testing bedside. What is happening here is that you have a cartridge. In this cartridge, the citrated sample is sucked in, and in the cartridge you have a membrane which is coated with the agonists like collagen, epinephrine or collagen ADP. उससे क्या होगा? The platelets will get activated, shape change होगा, they will aggregate and they will form a plug. So जिनका platelet function normal होगा, this plug will form soon. जिनका platelet function defect होगा तो ये plug नहीं बनेगा और sample अंदर aspirate होता रहेगा. So instrument measures the closure time. So a prolonged closure time would indicate that there is a platelet function defect. We are not using this system in our institute, and I'm not really sure how helpful also it is, because it might be used perioperatively, to screen patients for any obvious platelet function defect. But agar aap, if you are evaluating a patient with bleeding disorder, this is really not the equipment to be used, right? Got the point?
Yes, ma'am.
Yes, ma'am.
Okay. So, because there are many variables which can affect the results of PFA 100 or PFA 200. So, this is one of the commonly used things, and this is what is this?
Platelet aggregometer.
Aggregometer, right. So, so before you order platelet function testing, can somebody list some of the precautions which are important? Since you are not doing it, so I'll just tell you, platelets have a half-life of 7 days. तो ये बहुत ही dynamic structures होते हैं. They are affected, by diet. Suppose you have a lot of garlic and onion in your diet one night before. Suppose you are having drugs, antihypertensives, antipsychotic drugs, or even simple some antibiotics, some NSAIDs for fever. So all these things will affect your platelet function. So as a protocol, before you usually give a date for this test, क्योंकि आपको sample fresh process करना होता है. The processing has to be finished within 3 hours or 4 hours of collection. You cannot store samples when you are doing for platelet function testing, right? So we usually call the patient fasting overnight because it's a light transmission based testing. So you don't want your plasma to be lipidic and like that. So उसमें कोई turbidimetry नहीं होना चाहिए and turbid नहीं होना चाहिए and so all this history of drugs and diet, all this needs to be taken into account and patient should be guided accordingly before you give him a date and call him for a platelet function test, right? So I'll go to the principle what actually is happening, that you need a dedicated, as we've already seen, you need a dedicated equipment for doing a platelet aggregometry. So you have a light source and if you see a platelet poor plasma, so platelet poor plasma means your platelet count is less than. What do you mean by platelet poor plasma?
Less than 1 to 10 power 9.
Platelet poor plasma means your platelet count is less than 10,000. Right? How do you prepare platelet poor plasma?
Centrifugation and multiple washes.
Revolutions for about 15 minutes, 20 minutes.
At what speed or what G or what RPM?
2000 G.
Right, 2000 G or 3000 RPM. So that this is like known as a hard spin. So that if you do such a spin, it will result in a platelet poor plasma. Whereas for a platelet rich plasma, you need a soft spin. So it's usually around we do at 1000 RPM or maybe around 200 G to get a platelet rich plasma. So for this test, from the patient sample, you need both platelet poor plasma as well as the platelet rich plasma. The platelet count should not be less than 1 lakh. These are some prerequisites for the test, right? So before you are ordering this test, you should have done your basic CBC and you should know all the counts. So again, coming back to the principle, if this is a platelet poor plasma, there is nothing which is affecting the transmission of light. But in a platelet rich plasma, your platelets are there in a suspension and there is a diffraction of light. So the absorbance is low. But once you add your agonist, there will be platelet clumps. So now the transmission kind of increases so the detector will have more light which is passing through the same tube, right? And you have a stirrer at the bottom which helps to keep these platelets in suspension, right? So this is how once you add your agonist, this is how your graph would look like. So you have your resting platelets which are in suspension because of the stir bar. When you add your agonist, they'll be activated, they'll undergo a shape change, they'll undergo aggregation. So as they are aggregating, more and more light, if you can see, is going on increasing. So initially, if we say this is at 0% light is passing, once they have aggregated, almost 80-90% of the light is passing, right? So this is how you kind of interpret that there has been a reaction or there has been an aggregation. And this usual run is for 6 minutes, right? So you need a dedicated equipment and a software to run this test. So that's why people are shifting to flow cytometry now. So this is how in real time it would look like. This is your graph where again you get your result percentage aggregation over here. And this is the response to different agonists like ristocetin, ADP, collagen and so on. And we can see that there is a aggregation or a reaction to different agonists, right? So what has happened in our patient? So when we do, so there is some response to ristocetin. This is ristocetin. I'm sorry, I should have labeled it. Okay, it is labeled over here. So this is ristocetin. Whereas for all other, there is a flat line, right? So this means that once the agonist was added, it did not interact with specific receptors. There were no inside out or outside in signaling. There has been no platelet aggregation. This is a dead line, flat line, ECG line, right? So what are we dealing with? We are dealing with Glanzmann thrombasthenia. So this kind of a pattern would come in Glanzmann thrombasthenia when there is an absent response to majority of the agonist except ristocetin. Normally ristocetin should have come better, but even sometimes we see that even with ristocetin also the response is lower down. And further, we can confirm this by doing flow cytometry, as Arundhati correctly pointed out, that in Glanzmann thrombasthenia, there will be a defect of the 2B3A when we added anti-CD41. In a control, we have good expression of both 42 and 41. Whereas in my patient plasma, there is only 42, but 41 is absent, right? Any confusion? Any repetition? Did everybody get it? Am I too fast or am I too slow? You want me to speed up?
With ristocetin, when we add ristocetin, how it corrects glands, men thrombocythemia?
Ma'am, normally if you see, there should not be the ristocetin agglutination should not be affected, right? So standard way of teaching is key absent response to 1 minute. There is one more. Why has it kind of hung? Not able to move my slide.
Click on the screen once more time. One more time. Yeah. Now you are able to move.
Oh, yeah. So like you see, if you interpret the pattern of aggregation, so these are some of the common agonists which you use: ADP, ristocetin, collagen, epinephrine. Normally it is said that if there is an absent aggregation to all except ristocetin, then you start thinking of Glanzmann thrombocythemia. A close differential would be afibrinogenemia, but afibrinogenemia में तो आपका PT, APDT, everything would be abnormal, right? So ये आपका out हो जाता है because you have put a platelet function test because all your coagulation screen was normal. So further you can confirm it by flow cytometry. Ristocetin ka we have seen a variable response in our lab. It can be normal, it can be slightly reduced also, right? But rather more important is that the response to all other agonists like ADP, collagen, epinephrine, etc. all is subdued markedly, right? Whereas if you see vice versa, that rest all the responses are normal except for ristocetin, then you are probably dealing with either Burnout-Schroeder syndrome or von Willebrand disease. And for Burnout-Schroeder syndrome, what you can do is go back, have a look at the smear. Usually the platelet count is borderline 1 lakh के आसपास होगा, but even we have seen that 30-40,000 तक भी कभी-कभी Burnout-Schroeder patients can have a low count at that level also, right? Then you can do a flow cytometry and you will see that there is a defect in CD42B. For von Willebrand disease, Dinesh has already explained how you can go ahead and do even in platelet function testing में PRP में आधा PRP पेशेंट का लेकर के ऊपर से ऐड PNP, तो ऊपर से जब आप PNP या PPP डाल दोगे तो क्या होगा, ऊपर से उसको प्लाज्मा मिल जाएगा. रादर ऐड PPP, PNP नहीं. You want something which is without platelets. So पेशेंट का PRP and a normal PPP. So PPP में क्या होगा, वॉन विलेब्रैंड फैक्टर होगा. So अगर वो आप डाल दोगे अंदर तो now when you add ristocetin there will be an aggregation. So you can discriminate कि प्लेटलेट का डिफेक्ट था कि प्लाज्मा का डिफेक्ट था, राइट? सो पेशेंट के प्लेटलेट्स और ऊपर से प्लाज्मा, और प्लाज्मा मिलने से वॉन विलेब्रैंड मिल गया, राइट? आई होप आई एम क्लियर. And another scenario is when there is absent secondary aggregation curve to all the agonists. I haven't actually kind of explained in detail, but if you see जब आप platelet function testing करते हो, depending upon the concentration of the agonists, you get a primary curve, then you get a secondary curve. If you use low concentration, तो खाली agonist का receptor से interaction होता है, reversible aggregation होता है. But when the granular content gets released, at that time there is more cross-linking and a stable clot is formed. So that comes as a secondary curve, right? मुझे ऐसे blank faces लग रहे हैं थोड़े से, तो I'll just go back to the plot. So something, you know, like this. This is a primary curve and then this is the secondary curve, right? अगर मैं low concentration में ADP डालूंगी तो खाली ये reversible aggregation होगा और ये secondary curve नहीं आएगा. But if I use a high concentration agonist, I'll directly get something like I have here in the blue line, right? So जो storage pool defects होते हैं उनमें क्या होता है, अक्सर you just get the primary curve, but since there is a storage pool defect or a secretion defect, तो जो granular content था वो release नहीं होगा, इसलिए ये वाला part of the curve will not form, and rather here you will see that they start disaggregating and go back. ठीक है? I'm eating up a lot of time of your dinner, so I will speed up. So for secretion defects and storage pool defects, these are actually even rarer disorders. You will need more specialized tests like stimulate the platelets, उनका granular content plasma में आए, फिर वो plasma को store करके उस पे ELISA लगा लो against the specific metabolites, or you can use flow cytometry. You activate your platelets, तो CD62P का expression increase हो जाता है, CD63 का expression increase हो जाता है. So these can be monitored by flow cytometry. And sometimes you can also detect whether the phosphatidylserine exposure जो हमारा Scott syndrome होता है उसमें वो switch होकर के you can tag it with annexin and see if this is there or not. So these are specialized tests and you should just know about it. Not I'm not going to detail currently. सब कुछ तो बता दिया क्योंकि मैडम और क्या डिटेल बताने वाले थे. So okay, this is a spotter. What do you think it is?
Giant platelets. Bernard's
Giant
platelets.
platelets. Right? And there is a absent. This blue is for the patient and this is for the control. And this is ristocetin. So क्या हुआ है?
Sully syndrome, there is no reaction for ristocetin.
Right, so there is no reaction to ristocetin. Then मैंने जैसे पहले बताया कि मिक्सिंग किया हमने, प्लाज्मा डाल दिया ऊपर से, फिर भी क्या हुआ? ऊपर से प्लाज्मा डालने पर भी रिजल्ट नहीं आ रहा. इसका मतलब किस में डिफेक्ट है, प्लाज्मा में या प्लेटलेट में?
प्लेटलेट में.
वेरी गुड. सो प्लेटलेट में डिफेक्ट है, क्योंकि प्लाज्मा में डिफेक्ट होता तो करेक्शन आ जाता थोड़ा बहुत, है ना. सो प्लेटलेट में डिफेक्ट के लिए हम क्या कर सकते हैं? 41, 42B, and here we can see very nicely 41 का expression is there, like over here 41 is positive but 42B is
Negative.
absent. So this is a case of Bernard-Tolling syndrome. So we're coming to an end. Last case है ना, कौन करना चाहता है? Shiromani, I want to talk to you.
Yes,
Are
ma'am.
you there?
Yes, ma'am.
Very good. So Shiromani, so we have a
Yes.
12-year-old female. This was not given. So we have a 12-year-old
Yes.
female, positive bleeding history, petechiae, ecchymosis, spontaneous hematoma also. Family history is not significant. Coagulation screen is normal. Factor ऐसे भी लगा लिया. 8 भी normal है, 9 भी normal है, von Willebrand भी normal है, platelet function test भी normal है. अब
Okay. She's a young patient with petechiae ecchymosis, so it could be a primary hemostatic and platelet function test normal is, but we have not
एक
seen.
second, you missed the third line. उसके बाद spontaneous hematoma भी तो लिखा है.
हाँ, spontaneous hematoma भी है, ma'am. Yes, ma'am. But the family history is not significant. So platelet function test, ma'am, हम लोगों ने किया है, but platelet count भी normal है. So it could be.
So I'll rush because of the time limitation. वरना मुझे
Protein
delete करना
deficiency.
पड़ेगा. So when you have such a situation, right? So again, you have a which is pointing that there is some secondary hemostatic disorder also, right? You have a spontaneous hematoma, जो normally platelet function defect वाले patients नहीं आएंगे इस तरह से. So one important test which we have realized over time that we should put up is clot solubility. Right? So factor 13 deficiency में PT, APDT is normal, platelet function test is normal, platelet count is normal. But if you look at the history, it is giving you a clue that it is a secondary hemostatic defect, right? So you put up the clot solubility test. Again, this does not require any specific reagent. This we have also started putting up as a primary upfront. हम लगा देते हैं जब हमारे पास patient इस तरह का आता है तो you make a clot using 5 microliter sample and 500 microliter calcium chloride and dissolve it in 5 molar urea solution. अगर तुम यूरिया पाउडर खरीद लोगे तो तुम्हारी पुश्तों की पुश्तें भी वो पाउडर इस्तेमाल करती रहेंगी. ठीक है? And it's very cheap. So you just buy these things in your lab and you put up, you make a clot and you make it to stand in this 5 molar urea solution for 24 hours at 37 degrees centigrade. And what happens, since factor 13 is required for cross-linking these fibrin polymers, but लेकिन factor 13 deficiency में ये क्योंकि cross link नहीं बन रहा है तो this becomes a very weak aggregation. तो clot क्या होगा, dissolve हो जाएगा, whereas control में वो dissolve नहीं हुआ. Right? So this was a case of इस test की limitation क्या है? It will only pick up very severe deficiencies. So mild moderate deficiencies might get missed. For that, what would you do? You would do a factor 13 assay. So ये standard है जो बताना होता है हमें. I request Dinesh to come back, please, to end the session. And this is our team. Meena Madam, Vishwas and Aslam, who are actually the key backbone people जिनको आपको train करना चाहिए, जो primary intercept करते हैं, and you have to learn from them and you have to teach them also how to move things forward, right? So I'll stop sharing. Dinesh. Dinesh is back. So I hope you people understood some of these cases, and it might help you when you deal with isolated PT, isolated APTT, or both PT and APTT prolongation, and cases where the patient is still bleeding and everything is normal. Then what all to do? मुझे या दिनेश को कॉल कर लेना.
Okay, so purpose of this class is basically to deal with the simple day-to-day interpretation of the test and how to take the advantage of history. Okay, simple test, but big diagnosis. You can make it in your lab. So intentionally, we are not included any complicated type of test. We try to put the simple, straightforward cases which we encountered. Okay, so at least with the simple test, without any specific test, you can do these things. And next week there is class for Dr. Sukesh Nair. So we hope he will tell you more about these some interesting more cases, little bit more complicated. So I hope you people have understood. If you have any queries, any questions, any doubts, you can ask us.
There is a question that why do you use aged serum and not aged plasma?
Okay, so we use both ACE serum and ACE plasma. Okay, so the difference is whenever we found the deficiency, we want to find the deficiency of ACE factor 2, that is prothrombin deficiency. Okay, so neither ACE serum or not adsorbed plasma have factor 2 because it has been consumed. Okay, one, it is removed by barium sulfate, in other in fibrin formation because it formed the clot. Okay, so that's why factor 2 is not there, but in ACE plasma it is there. So if it is not correcting with your ACE serum, ACE plasma, adsorbed plasma, and your PT APTT is both prolonged and patient is presented with coagulative type of disorder and it is corrected with ACE plasma, then it is factor 2 deficiency and your TT should also be normal. Okay, that's how it is. Not like that we don't use, but majority of the time prothrombin deficiency is very rare condition, but this ACE plasma is used in that condition.
Adsorbed plasma का quality check कैसे करते हैं?
Okay, adsorbed plasma. So basically, as ma'am has already explained, when you take the 1 ml of your pool normal plasma, which contain all the factors, then you add 100 milligram of barium sulfate and vortex it for 5 to 7 minutes, and then centrifuge it and do a PT on supernet. If your PT is more than 60 seconds and less than 120 seconds, that means all the vitamin K deficient factors has been adsorbed. Okay, so now your adsorbed plasma is perfect. So your quality control is you have to do PT on these adsorbed plasma, and PT should be more than 60 seconds and less than 120 seconds. So it will be not over adsorbed on the other factors. Any other questions you people have?
किसी ने लिखा है फिर से सेमी लॉग ग्राफ एक्सप्लेन करो. आओ वो क्या हवेली पे आओ, तुम्हें पास बिठा के आराम से समझाएंगे.
Okay.
ठीक है. You want to explain again?
We have already over time, and I have already explained 2 times. So I think next time you can whoever is there, you can note down my email ID diness3224@gmail.com. Then you can contact me and I will send you a detailed procedure how to make a graph and other things. Okay, and if you can do a video call to me, and then I can explain you in person how you should make a factory graph on semi-log paper.
Most of the questions were answered. Thank you, Dr. Ruchi ma'am and Dr. Dinesh sir for a very extensive class. I'm a practicing oncopathologist. Even I got to brush up all my coagulation. Thank you so much. I think all the students will be grateful for that.